Okay, guys, so welcome back to the lecture. Now we're going to talk about some acid-base disorders, acidosis and alkalosis. So acid-base disorders result from imbalances in the acid-base equilibrium. When the blood pH is less than the reference range, less than 7.35, it is termed acidemia or acidosis, which means there is an excess acid or excess hydrogen concentration. This will result if hydrogen ion concentration increases through increased PCO2 or through decreases in the bicarbonate concentration. On the other hand, when the pH is greater than the reference range, the condition is termed alkalemia or excess base or alkalosis. It will result with hydrogen ion concentrations that are decreased, either from decreased PCO2 concentration or increased concentrations of bicarbonate. Okay, so we are going to discuss some primary acidosis and alkalosis disorders, whether they are respiratory or non-respiratory or metabolic. A primary respiratory acidosis or alkalosis is a disorder that is caused by ventilation, by ventilatory dysfunction, which means there has been a change in the partial carbon dioxide, which is the respiratory component. The non-respiratory or the metabolic disorder comes from, it is a disorder that comes from a change in the bicarbonate level, which is typically also called a renal or a metabolic function or dysfunction for that matter. Now, when you see issues with acid-base disorders, you may also see instances in which there is partial or full compensation. This means that there is a response by the body to maintain acid-base homeostasis. It is accomplished by altering the factor not associated with the primary process. So always think of the organ or the factor that is opposite to what is causing the primary disorder, okay? So either a respiratory issue or a non-respiratory or metabolic issue. So when compensation occurs, whether it's partial or full, it's coming from the opposite factor or the opposite organ. Okay, so mixed acid-base disorders arise from the presence of more than one process or compensatory mechanism in response to the primary disorder. For example, if the imbalance of a metabolic origin is of metabolic origin, the body compensates by altering ventilation. On the other hand, for disturbances of the respiratory component, the kidneys will compensate by selectively excreting or reabsorbing specific ions. So with this said, and I said this in the earlier lecture today, the lungs will try to compensate, but the response that the lungs have is an immediate response. They immediately compensate by retaining or expelling carbon dioxide. This again is a short-lived response and it's often incomplete. The kidneys, on the other hand, are slower responders. They respond in 2 to 4 days, but their response is long-term and typically sustained. Compensation again can occur fully or partially. Full compensation means that the pH has returned to normal ranges. So that means that the ratio of bicarbonate to carbonic acid is back to 20:1. So that has been restored. If there is partial compensation, that means the pH is approaching normal levels, but it's not yet there. Okay, so now we're going to talk about metabolic acidosis. This occurs when the amount of acid exceeds the capacity of the buffer system and there is a decrease in bicarbonate to less than 24. Remember in the last lecture I said bicarbonate should be at 24. Well, here is when you start seeing the acid-base imbalances. So again, a primary metabolic acidosis occurs when the amount of acids exceed the capacity of the buffer system, and there is a decrease in bicarbonate to less than 24. A decrease in the pH is due to decreased ratio of metabolic to respiratory component in our Henderson-Hasselbalch equation. Remember, we mentioned the 20-to-1 ratio? Okay, so the ratio will have an effect on the pH. When there is a decrease in a ratio, this will affect our pH as well. So in this particular case, in which there is a decrease in bicarbonate, okay, which is in our numerator, right? And so there's a decrease in the pH, the body will try to compensate for this issue for metabolic acidosis with hyperventilation, so releasing more CO2. So some of these metabolic issues, acidosis issues, can be caused by acid-producing substances, production of organic acids in diabetic ketoacidosis, reduced excretion of acids as seen in renal tubular acidosis, and excessive loss of bicarbonate from diarrhea or drainage from biliary, pancreatic, or intestinal fistulas. Here are some symptoms for primary metabolic acidosis, and that includes central nervous system depression, confusion, neurologic symptoms that can be exacerbated all the way to a coma, the lack of energy, sleepiness, breathing rapidly, nausea, and flushed skin. In the laboratory results in primary metabolic acidosis, what you'll see is a decrease in bicarbonate as well as a decrease in pH. If this issue is compensated, you'll start to see a decrease in the partial carbon dioxide. Compensated pH should be back to normal, which means it should be back at a normal range between 7.35 to 7.40. Okay, our next disorder will be a primary respiratory acidosis. Okay, so with this said, you know it's acidosis, so you know that the pH levels will be down. So here there is a decrease in alveolar ventilation, so there is hypoventilation, causing a decreased elimination of carbon dioxide by the lungs. So the respiration is regulated in the medulla of the brain. But again, the work is happening in the lungs, right? This respiratory acidosis can be caused by ineffective removal of carbon dioxide from the blood through lung disease or because of lung disease, or in cases of COPD where there is airway obstruction. In these cases, there are changes in the air spaces leading to reduction of lung surface area. CO2 is retained in the blood, causing chronic hypercarbia, which means there's elevated PCO2 levels. Other instances that cause primary respiratory acidosis can be drugs such as barbiturates, morphine, or alcohol, decreased cardiac output such as in congestive heart failure. And compensation of respiratory acidosis will occur through the opposite system, which is the metabolic or the non-respiratory system. But this will take hours to days to affect the pH. Remember, the kidneys, when they respond to regulate the pH, is a slower response, so it takes 2 to 4 days. The kidneys will respond by increasing the excretion of hydrogen ions and reclaiming bicarbonate, okay? Remember, there's acidosis, so you want to reclaim the bicarbonate. Bicarbonate increases, causing the pH to come back to normal. Okay, so, and here are some symptoms of primary respiratory acidosis. So there is slow or difficulty breathing. Remember, there is a decrease in the elimination of carbon dioxide here, and that is happening because of hypoventilation. Okay, now hypoventilation can occur because of many different reasons. It can cause headaches, drowsiness, confusion, and decreased levels of consciousness. It can cause muscle twitching, which can progress to convulsions and palpitations. In the lab, it is acidosis, so you'll see a decreased pH and increased PCO2, which is in the denominator of our Henderson-Hasselbalch equation. So it will be the opposite of the pH and decreased oxygen levels. If it is compensated, you will see an increase in bicarbonate levels and also a normal pH level. Okay, so now we're moving on to primary metabolic alkalosis. So now we know that it is alkalosis, so our pH is increased, right? So here what happens is that there is a gain in bicarbonate that causes an increase in the pH. Remember, bicarbonate is placed in the numerator of the Henderson-Hasselbalch equation. This can be caused by excess administration of sodium bicarbonate or through ingestion of bicarbonate-producing salts. There is also excessive, or another issue, or another reason could be through excessive loss of acid through vomiting, nasogastric suctioning, or prolonged use of diuretics that increases renal excretion of hydrogen. The hypokalemia and chloride deficit stimulate the reabsorption of bicarbonate in the distal tubules. Compensation occurs when hydrogen ions in senses in brain signals respiratory center to slow down the respiration, which then results in hypoventilation, and then that increases retention of carbon dioxide. This then increases partial carbon dioxide and lowers the pH. Okay, the primary cause of metabolic alkalosis needs to be corrected. Okay, so this gain in bicarbonate has to get corrected. So here are some symptoms of primary metabolic alkalosis: some shallow breathing, irritability, twitching, confusion, and picking at bedclothes, and some rapid heartbeats. What you'll see is an elevated bicarbonate level as well as an elevated pH, an increased base excess on the arterial blood gases, and if it is compensated, you'll see an elevated CO2 and also a normal pH, a pH back to normal. Okay, and lastly, here we have primary respiratory alkalosis. So again, we know that it is an issue with the pH being increased, and the primary issue is happening in the respiratory component. Here, what's happening is that there is an increase in alveolar ventilation, causing excessive elimination of CO2 by the lungs. And that can be caused by hypoxemia or hysteria induced hyperventilation. Also, chemical stimulation of the respiratory center by drugs like salicylates and nicotine. Also, it can be caused by pulmonary emboli or pulmonary fibrosis, in which pulmonary oxygen exchange is impaired. Compensation will occur through the non-respiratory component, which is the kidneys, by excreting bicarbonate in the urine and reclaiming hydrogen to the blood. And here are some symptoms of primary respiratory alkalosis, in which the patient can feel headaches or vertigo, feeling very dizzy, agitation, tingling or numbness around the mouth and fingers, and tinnitus, which is ringing in the ear. The lab results will be decreased partial carbon dioxide, an increased pH, and obviously an increased bicarbonate level. But if it is compensated, you'll see a decreased bicarbonate level and a normal pH, a pH that will go back to normal. And with that said, this ends our acid-base disturbances and acid-base imbalances. And now we will move on to learning about oxygen and gas exchange in the next lecture.